Welcome! In this explainer, we're going to break down the must-know meds for managing gastric hyperacidity. If you're getting ready for the NCLEX or just trying to sharpen your skills on the floor, understanding these drugs is, well, absolutely essential. So let's get right into it.
Okay, let's start with the most basic, most fundamental question you're going to face. Are we trying to neutralize acid that's already there? Or are we trying to reduce how much acid the stomach is even making? Seriously, the answer to that question changes your entire game plan. It's a huge critical thinking point for your exams.
First up, let's talk about the neutralizers. These are your frontline defenders, the quick fix crew of the stomach med world. We're talking about antacids. What I love about this is just how simple it is. So you take something like calcium gluconate. Its whole job, its mechanism of action, is super direct. It just neutralizes that stomach acid. And as a bonus, it inactivates pepsin, which is this digestive enzyme that can really tear up the stomach lining when things get too acidic. That direct action is exactly why it's so good for immediate relief from heartburn. And this analogy, it's perfect. Antacids are literally like firefighters rushing to a scene. They show up, they douse the flames of the acid that's there right now, and they give you that fast relief. But, and this is a big but, they don't fix the source of the fire. They don't stop more acid from being produced later on. So this right here is where you really need to pay attention for your exams. For antacids to work right, the patient has got to chew them up really, really well, and they have to follow it with a full glass of water. But the biggest, brightest red flag, the one that will get you on an exam, is that last point. You have got to avoid giving them within 1 to 2 hours of other medications. They can totally mess with the absorption of other drugs. Okay, so let's move on to the next major category. Now we're talking about the reducers. These are the drugs that go straight to the source of the problem and actually decrease acid production. This group has two absolute heavy hitters: the H2 blockers and the proton pump inhibitors, or as you'll always hear them, PPIs. This slide lays out the difference perfectly. Think of it like this, okay? H2 blockers, they're like signal jammers. They intercept a message, the histamine signal, that's telling the stomach, hey, make more acid. PPIs, on the other hand, they're way more direct. They go straight to the factory machinery, that proton pump, and they just shut it down. That's why PPIs give you a much more powerful, longer-lasting suppression of acid. So let's zoom in on a classic H2 blocker, famotidine. You can see right here, by blocking those H2 receptors, it brings down acid secretion. And that makes it the go-to choice for those more nagging issues, right? Like GERD and peptic ulcer disease, not just a little bit of heartburn now and then. Now, with H2 blockers, timing is absolutely everything. For them to really work, your patient has to take them before they eat that spicy meal that's going to trigger their heartburn. And here's a massive clinical point. Always, always, always check if your patient has kidney or liver problems. Their dose will almost definitely need to be adjusted. That is a classic NCLEX safety question right there. And now for the big guns, the PPIs. Take a look at omeprazole. Its whole job is to directly shut down that proton pump. And that leads to some seriously powerful, long-lasting acid suppression. This is why we use it for really tough conditions like GERD, and why it's a key player in treating H. pylori infections, usually with a couple of antibiotics. So to go back to our analogy, if H2 blockers are just jamming the signal, PPIs are the engineers who walk right into the acid factory, find the main valve, and just crank it shut. It's a much more profound action, and it has a much, much longer effect on how much acid gets made. The clinical alerts for PPIs are so important. Especially when a patient's been on them for a while, you gotta know how to give them. Like, you can mix the little granules with applesauce, but don't you dare crush them. But what's even more important is monitoring for those long-term problems, like low magnesium, zinc, and B12. When you reduce stomach acid for a long time, it can really mess with how the body absorbs nutrients. All right, so we've covered the neutralizers and the reducers. Now let's talk about two other really important players that have completely different jobs. We're talking about the protectors and the gas busters. Let's kick things off with sucralfate. Now, look closely at its mechanism. It doesn't do a single thing to acid levels. Nope. Instead, when it hits that acidic environment in the stomach, it turns into this thick, sticky paste that gloms right onto an ulcer. It basically forms a shield, protecting the ulcer from any more damage so it can actually heal. This is honestly the perfect way to remember what sucralfate does. It's not a chemical that's changing the stomach's pH. It's a physical barrier. A liquid Band-Aid that literally goes in and covers up the wound. Now for this liquid Band-Aid to work. It needs a nice, clean surface to stick to, right? That's why the absolute most crucial point here is that you have to give it on an empty stomach, usually about an hour before meals. And be super careful with renal patients. Some of the aluminum in the drug can get absorbed, and in someone with bad kidneys, it can build up to toxic levels. And last but not least, we have simethicone. This one isn't worried about acid or ulcers at all. It's all about gas. Its job is simple. It changes the surface tension of all those little gas bubbles in your gut, causing them to break apart into smaller bubbles that are way easier to, well, pass. It's all about relieving that awful, painful bloating and pressure.
The tips for this one are just really practical. Simethicone works best when there's actually food and gas in the stomach, so giving it after meals and right at bedtime is perfect. And a simple one that people forget all the time, if you're using the liquid form, you have to shake it well. Got to make sure the medicine is mixed up right.
Okay, wow, we have covered a lot of ground. So let's pull everything together into one final rapid-fire safety checklist. These are the absolute must-know things to keep your patients safe and to totally crush your exams. Here they are. Number 1, antacids play by their own rules. Separate them from other drugs by at least an hour or two. 2, sucralfate needs that empty stomach to do its magic. 3, if your patient's on a PPI long-term, you become a nutrient detective. Watch those magnesium and B12 levels. And 4, when you see an H2 blocker, your brain should immediately think kidneys and liver. Do I need to adjust that dose? Burn these 4 points into your memory. And really, this quote says it all, doesn't it? It's not enough to just know the names of the drugs. For this whole group of medications, timing and patient-specific factors are everything. Getting the timing wrong can make a perfectly good medication totally useless or even dangerous. So how are you feeling? Do you feel like you've really got the difference between a neutralizer, a reducer, and a protector? Well, the best way to really know for sure is to put yourself to the test. Head on over to nursingwithcharity.com.ng and take the NCLEX challenge quiz on this exact topic. And just as a final reminder, this explainer is a tool to help you study and really get these concepts down. It is not medical advice. It's here to help you with your formal education and your clinical supervision. So keep learning and stay sharp out there.